Very good. So, good evening, everyone, or good afternoon, everyone. So, it's a pleasure to welcome you all in AIPNO Research Showcase. This is our room one, where we have some excellent 19 posters and presenters going to share with us about their exciting findings of their research or what they're up to academically. Our first presenter is Karina Pedersen. She is from NeoMed, and I will give the podium to her. Move forward, please.
Hello, everybody. My name is Karina Peterson, and I am a second-year medical student at NeoMed. My project looked at the efficacy of conventional therapies for perianal fistulizing disease in patients with an ileopouch anal anastomosis. An ileopouch anal anastomosis is a procedure that's done in patients with ulcerative colitis who have to have their large bowel removed, and it basically restores normal bowel function and continuity. Unfortunately, a lot of these patients also develop Crohn's disease, which predisposes them to perianal and pouch-associated fistulas. And also, more unfortunately, these fistulas are very difficult to treat, with only 52% healing after several operations and 80% after complete pouch excision. And up to 38 patients will actually be left with a permanent ileostomy. So current literature has examined the efficacy of individual procedures to treat rectovaginal and perianal fistulas, however, has yet to examine the efficacy of several different procedures in relation to patients with an ileopouch anal anastomosis to heal perianal and pouch-associated fistulas. So our study wanted to look at the overall efficacy of current therapies to treat fistulas in patients also with an ileopouch anal anastomosis, and also identify risk factors associated with healing or recurrence of the fistulas. Our study was a retrospective study of patients greater than 18 years old who underwent an operation for perianal, rectovaginal, or pouch-associated fistulas with a concomitant ileopouch anal anastomosis between 1995 and 2021 at the Cleveland Clinic Foundation. To achieve our goal, we wanted to look at stages of pouch surgery, medical management of Crohn's disease or ulcerative colitis, and complications alongside this, the pouch surgery, such as anastomotic leak, pouchitis. We also recorded several perioperative parameters with the fistula surgeries. In terms of statistical analyses, a univariate analysis will be used to identify single factors associated with healing. Multivariate logistic regression will be used to find risk factors associated with healing, and subgroup analyses will evaluate pouch function and outcomes in relation to healing. Unfortunately, this statistics are not back yet on this project. However, all data has been collected, and we are including 221 patients. Overall, there is a lack of large-scale studies of fistula therapy in patients with an ileopouch anal anastomosis and fistula recurrence. So phase 1, 2, and 3 clinical trials are ongoing for mesenchymal stem cells to treat perianal fistulas in patients without an ileopouch anal anastomosis, however, have yet to examine the outcomes with. So this is an ongoing study, and hopefully we can identify some important risk factors so we can best inform patients of their prognosis.
Very good. We will switch over to our next speaker, Meghna Chanamolu, who is going to speak on core triatum, a narrative review. Please move forward.
Okay. Hi, everyone. My name is Meghna. I'm a M3 medical student at NeoMed as well. And today I'm going to be presenting core triatriatum, which is a heart condition in which you have a thin fibromuscular membrane that's going to split either of the right atria or the left atria into two, creating some sort of like a 5-chamber heart, as you can say. It is a congenital heart defect that is almost like that has an incidence of 0.1% in all patients with congenital heart problems. It's usually it can present in 2 different pathologies. One is core triatriatum sinister, which is the most common form that it presents in, and it's because of a membrane that's going to go and divide the left atrium, and which this forms due to, there's many theories that are backed up behind as to why that you have this sort of membrane that's forming, but the most common one that's known is the malincorporation theory, which is basically that you have the failure of the pulmonary veins to fuse with the left atrium, but that's why you're going to have a really narrow pulmonary venous ostium. And since that later gives to an appendage, which then forms as the membrane that's blocking the left atrium. So in which it creates a huge like hemodynamic obstruction in the flow of blood. Another presentation that it has is core triatrium dexter, which is when you have a fibromuscular membrane that's going to go and split the right atrium, in which this is going to form when you have the failure of your it's like with failure of the right-sided sinus venosus valve remnant from regressing, like that fails to regress, then it's forming as a membrane which blocks the right atrial blood flow. So in common forms that these are going to present, it's most likely going to be due to the size and the number of fenestrations and basically the makeup of the membrane itself. Some of the ways that it presents are like tachypnea, wheezing, murmurs, cough, and pulmonary congestion, and it can lead to cardiomegaly and congestive failure depending on how long the child survives with it. So some of these can be immediately after birth and some can occur multiple years later. In adults, it's usually asymptomatic, and it presents really later in life because of the fact that their membrane is like not that significant in causing an intra-atrial pressure gradient, and not much of a major obstruction is present. The diagnosis is mostly done via many imaging methodologies. The most common one is echocardiography, but it can also be done via angiography, chest X-ray, ECG, and cardiac CT. The main way to treat it is usually through a cardiopulmonary bypass via surgical, usually done in neonates, but in adults, catheter-based ablation is also very prominent. And it's because of the fact that this pathology presents very, very similar to a lot of other cardiac pathologies, congenital heart diseases, and the fact that it's really rare in presentation. It should be this, like, knowing a little bit more about this pathology in general will like aid a lot of cardiologists in order to like diagnose it early on, rather than going a lot of years like undiagnosed. And that's why it should be important to stress the knowledge about it.
Great. So we have next person, Layden Lozada Jimenez. Validity of sleep-related breathing disorders, SRBD in anthropometrics and obese overweight children. Layden.
Hi.
Yours.
Hi, all. How are y'all doing? My name is Layden Lozada, and I'm a former sleep medicine fellow at the Cleveland Clinic. I'll be presenting the validity of sleep-related breathing disorder scale and anthropometrics in obese and overweight children with obstructive sleep apnea. OSA has been associated with higher morbidity rates and suboptimal responses to standard therapy in obese and overweight children. Untreated moderate to severe OSA in children is characterized by episodic nocturnal hypoxia, increased arousability, and oftentimes hypoventilation, culminating in a range of serious metabolic, cardiovascular, and behavioral consequences. Thus, early screening and detection of OSA in this population is of paramount importance. We studied 89 obese and overweight patients in our database that had complete data on SRBD. We used a receiver-operated characteristic analysis with AHI as the outcome variable. We included sensitivity, specificity, positive and negative predictive values for an SRBD cutoff score of 8. We obtained the SRBD score using the ULIS index. We included prediction models, interaction, and discrimination using the AHI as the outcome, and as independent variables, we included age, sex, SRBD, waist, and neck circumference. Our study population characteristics included patients aged 12 plus minus 3 years. 55% of our patients were females, 62% of them were non-white, and the AHI ranged from 13 plus and minus 20. 61% of these patients had moderate OSA, and 37% of these patients had severe OSA. As you can see on table 1, we can describe sensitivity, specificity, positive and negative predictive values using the SRBD cutoff score of 8 and AHI cutoff scores of 5 and 10. We found that the sensitivity was fairly high, but the sensitivity was very low in all outcomes. The figure to the right shows the area under the ROC curve that was 0.50 and 0.56, indicated that in this cohort, using SRBD to predict moderate to severe sleep apnea is no better than chance. And on table 2, we can see the multivariable logistic regression models, including odds ratio, 95 confidence intervals, and associated p-values for the models of AHI over 5 and 10 that include and exclude SRBD total score. We found that SRBD total score was not a significant predictor of either moderate or severe OSA. In conclusion, SRBD alone had high sensitivity and low specificity for significant OSA in overweight and obese children. And the addition of anthropometrics to SRBD resulted in worse discrimination of OSA for these 89 patients. Thank you.
Very good. Next, Dikshita Balaji, therapeutic drug granted breakthrough description by the US FDA 2012-2020. Dikshita.
Hi, everyone. I'm Diksha Balaji. I'm a third-year medical student at CASE, and I'm going to be talking about some patterns in the breakthrough designation given by the US FDA from 2012 to 2020. So the US FDA has a lot of programs that aim to expedite the review of drugs that are treating serious or life-threatening conditions. So these drugs can get to the market faster. One of these conditions is the breakthrough therapy designation. So if a drug is granted that designation, it only needs preliminary clinical evidence to be approved rather than it requires slightly less clinical evidence than another drug, and it receives some extra administrative support from the FDA. So we are looking at patterns in drug approval when drugs get this designation. So designation is different from approval. Designation is when the drug gets breakthrough status, and approval happens after designation. So for our methods, we looked at publicly available data from the Center for Drug Evaluation Research, which gives these designations. And we analyzed this data. So here is the table from 2012 to 2020. And we found that a total of 190 drugs out of 917 were given the designation. And some of the median of requests received over these years was 106. Of these, 40% were granted, 46% were denied, and 12% were withdrawn. And if a drug was given the breakthrough designation, it did not mean that it later got approval. And why this is important is because the breakthrough designation was created to support only a few drugs, and it was expected to support only a few oncologic drugs. But the program has become increasingly popular since 2012. So as you can see, in 2012, 0 were approved, and now in 2020, 34 were approved, and the number of requests has gone up from 2 to 125. So the program is becoming more popular, and it should be an area of concern because these drugs are getting approved with slightly less evidence than the standard procedure would allow. So it's important to have further analysis into this area, because while the breakthrough status is important for bringing drugs to market that are important to patients, it also brings to market drugs that were approved based on more limited clinical trials. So we recommend that more analysis be done on drug performance post-approval to assess the function of the breakthrough designation. Thank you.
Okay, very good. Very good. The next is Payal Vora. She's going to speak on impact of adult day service centers, closure, and time of COVID-19. Payal.
Hi, everyone. So my project is on the impact of adult day service center closures and COVID-19. So just some background for those of you who are not familiar with adult day service centers. They're a form of community-based long-term care. So they are different from nursing homes in the fact that the participants don't stay there overnight. They're just dropped off for the day. They have activities for them, and then they're picked up at the end of the day. So they provide all kinds of services. They provide medications to the older adults that go there. They have social activities, and they're also a way for caregivers to go about their daily activities and also provide care during the night for the participants. So during COVID-19, a lot of these centers did close. And so what we wanted to explore was what was the effect of these closures on the centers, on the participants, and on their caregivers as well. So we had a sample size of 20, and we did some virtual focus groups and semi-structured qualitative interviews with the staff of adult day service centers. And what we found is that there's been a lot of decline in terms of physical health, cognitive decline, and mental health in the participants. And we found that there's also a lot of caregiver strain. So the way that the centers have adapted is they've come up with some virtual programming and socially distant programming. So they have virtual music therapy, virtual exercise classes, and also drive-in programs to help the participants and their caregivers get the respite that they need. So overall, what we found is that even though there are declines and they are able to accommodate COVID-19 and social distancing with these virtual programmings, there are still challenges, but they've come up with some creative solutions that hopefully will also be able to be implemented even after the pandemic is done. We would like to see some more research on how effective the remote programming is, because it is different to have the caregiver drop off their loved one versus have them log into a computer in terms of the respite that they receive. And we also advocate for better reimbursement for these adult day service centers because they are such a crucial part of the community and such a crucial part of the lives of the participants and the caregivers with or without a pandemic. Thank you.
Very good, Payal. The next is Cavalieri-Giri, inflammatory biomarker as a prognostic scoring model for peritoneal malignant mesothelioma.
Is there a way for someone to pull up my page or? Okay, I'll figure.
So sorry for the inconvenience. Sorry, Keval, we will get back to you. The next is Kabir Gulati, significant opportunities for guideline-based fatty liver screening in older children with obesity findings.
Hi, my name is Kabir Gulati, and this is my project titled Significant Opportunities for Guideline-Based Fatty Liver Screening in Older Children with Obesity, Findings from a Big Data Analysis. In this study, we answered the questions: how well are guidelines for screening for fatty liver being followed in obese children, and do disparities exist for screening of fatty liver in obese children? The American Academy of Pediatrics recommends that screening for fatty liver should begin between ages 9 to 11 in all obese children. The objective of my study is to determine screening rates of fatty liver in a large population of obese children and to determine socio-demographic trends in fatty liver screening in obese children. We used Explorers to determine fatty liver screening rates in obese children. Explorers contains population-level electronic health record data from 360 hospitals and over 300,000 providers across the U.S. We searched children aged 10 to 14 with any visit type in the last 5 years. Obesity was determined based on 1, any BMI that was greater than or equal to the 95th percentile, 2, a diagnosis of obesity, and 3, any finding of obesity. We defined our various populations: the general population, the obese population, the ALT screened obese population, and the ALT abnormal obese population. Rates of ALT screened were calculated for the following 3 demographics: gender, race, and insurance. Each of the demographics was converted to binary categories: gender to male and female, race was white and non-white, and insurance was Medicaid and non-Medicaid. Out of 3.5 million children aged 10 to 14, 14.4% were obese, and of the children that were obese, only 9.3 were screened for fatty liver, which shows a major failure in the following guidelines, and 90% of the population was not screened where it should have been. 16.5% of our obese population had abnormal ALT. Odds ratios were calculated to compare categorical data and percentages. For ALT by gender, we found that obese females were more likely to be screened for fatty liver than obese males. For ALT by race, we found that obese white teenagers are more likely to be screened for fatty liver than obese non-white teenagers. And for ALT by insurance, we found that obese teenagers with Medicaid insurance were more likely to be screened than those with non-Medicaid insurance. In conclusion, our study revealed that percentages of older children with obesity receiving screening for fatty liver was very low at only 9.3%. We found that the female gender, white race, and Medicaid insurance all led to increased fatty liver screening rates. These findings provide significant opportunities to increase guideline-based fatty liver screening among obese children across the country. Promoting screening for fatty liver as a health quality measure and incentivizing screening using value-based payment models may help reduce implementation gaps in screening for fatty liver in children with obesity.
Yeah.
Thank you.
The next person is Anira Iqbal.
Good evening, everyone. My name is Anira Iqbal, and I'm a third-year medicine resident at Cleveland Clinic. I'm here to present our project. This was a single tertiary care institute quality improvement project. We identified 176 patients in primary care clinics who had high-risk diabetes as defined by age more than or equal to 50 years, a hemoglobin A1C of more than or equal to 9%, and 2 or more comorbidities. 22 of these patients were agreeable, and they were exposed to a multidisciplinary team over a short period of time, which was 12 weeks. This multidisciplinary team included sequential visits with an endocrinology provider, a diabetes educator, and a pharmacist. After 12 weeks, these patients were then returned to their primary care physicians. At the end of 12 weeks, there was a significant improvement in this group's glycemic control, as was evidenced by their A1C reduction by 2.1%. This was statistically significant and was our primary outcome. We did not notice a significant change in our secondary outcomes, which were the amount of albuminuria and BMI. A limitation of our project was the small study size and the lack of a control group, since this was a quality improvement project. We are working on a matched study with similar patients who did not undergo this intervention. Implementing our project might assist primary care providers in managing high-risk patients with diabetes, and it might potentially improve outcomes while reducing therapeutic inertia, which is a problem that we face with elderly patients with diabetes and poor glycemic control, who are anyway at higher risk of complications, and they are prone to therapeutic inertia on the side of physicians, and this could lead to worse outcomes. Thank you.
So the next person is Raghav Shah.
Hi, everybody. My name is Raghav Shah. I'm a third year at The Ohio State University. The project I'm presenting today is hypertension cardiovascular outcomes in ADPKD patients in the format of a systematic review. So ADPKD is characterized by the progression and development of renal cysts that is one of the most common disorders that leads to ESRD or end-stage renal disease. It's known to affect approximately 12 million people a year worldwide and manifests into extrarenal outcomes such as liver cysts, intracranial aneurysm, and hypertension. As hypertension is a frequent and severe complication of ADPKD, it can spur the progression of other cardiovascular outcomes that can lead to vascular disease in both the adult and pediatric populations. And thus, it is crucial to identify how the early onset of hypertension in ADPKD patients progresses to aid in the management of ADPKD. So the objective of the study was to assess and identify the influence of early onset hypertension on other cardiovascular outcomes, specifically left ventricular mass index, carotid intima media thickness, and pulse wave velocity in ADPKD patients. In terms of methodology, a comprehensive search of existing literature was conducted where any studies including ADPKD patients with a positive status for hypertension or borderline hypertension were included for analysis. And 3 specific study variables regarding cardiovascular outcomes were analyzed, as I mentioned, left ventricular mass index, CIMT, and pulse wave velocity in both hypertensive ADPKD patients, normotensive ADPKD patients, and healthy controls. The compiled pool of data resulted in 1,297 hypertensive ADPKD patients. In addition, there were 342 control patients that were either normotensive ADPKD patients or healthy control patients. The results showed that there was a significant increase in the mean value of left ventricular mass index in both the adult population and the pediatric population, as well as there was significant rise in the CIMT and pulse wave velocity measurements in ADPKD patients with hypertension controlled or compared to normal control patients. As this data corroborates the onset of hypertension and how it accelerates cardiovascular manifestations, blood pressure evaluation is important for the management of patients with ADPKD. This high LVMI, PWV, and CIMT indicates increased prevalence of arterial stiffness, hypertrophic vasculopathy, and atherosclerosis, which suggests that vascular disease is prevalent before and during ADPKD and accelerates the progression of kidney disease. This causal relationship highlights the importance of monitoring hypertension and screening for cardiovascular screening in ADPKD patients. Thank you.
Okay, next person is Nikhil Nair.
Hi, everyone. My name is Nikhil Nair. I'm a current M1 at CWRU School of Medicine. I'm presenting on the validation of the STARS neonatal acute kidney injury risk stratification score. A little background. Neonatal AKI is one of the leading predictors of mortality and morbidity amongst neonates, especially in low and middle income countries. Worldwide, the approximate prevalence rates between 18 to 70% based on the resource, study, and country. And as such, being able to have a useful tool to identify which neonates are at risk for developing AKI can be crucial to preventing countless deaths each year. While there are few, such as the P-rifle score for pediatrics and the rifle score for adult populations, there isn't a true independent and unique risk stratification score for neonates itself. Most of what's being used currently is based on the adult and the adolescent population. So as such, the STARS acute kidney injury risk stratification score was developed for this purpose. With a multi-center national prospective cohort study out of multiple centers out of India, and it had two main goals in mind. First, to develop the risk stratification score itself and to identify which risk factors would be prevalent or important for the score, and then to further validate the score itself to see the efficacy and whether you can implement it on a wider national and international scale. And so we found over looking at 1,000 plus patients is that the risk stratification score had a pretty high or positive predictive value of 81.2% and high sensitivity and specificity for detecting and predicting which patients would develop neonatal AKI, and uses 10 distinct variables, including previous cardiovascular defects, gestational age, urine and serum output, amongst others, and uses them to calculate a nice, neat score. So if you look at the figures, you can see an example of a low-risk AKI children and a high-risk child or a child at high risk for AKI. And it can be done by any member of the healthcare team. And what we found is that it had pretty good diagnostic value. Using an ROC curve, we got a value of 93%, showing it has some distinct and credible diagnostic use in these situations. And a score of above 31.5 on a scale of 0 to 100 is pretty prognostic for a child developing AKI. Or a neonate developing AKI. So in conclusion, the use of this risk stratification score, especially in low and middle income countries, can be critical to allowing and preventing countless death, mortality, and morbidity amongst the neonate population, and can allow for earlier interventions to save countless lives. Thank you.
Great. Next person is Nikhil Dalta.
Hi, my name is Nitin Dalla. I'm a senior at Springboro High School, and I'll be talking about Fabry disease management and carriers for enzyme alpha galactosidase. And so Fabry disease is an X-linked recessive deficiency of the enzyme alpha galactosidase, resulting in the accumulation of GB3 within lysosomes of a variety of cells. It is actually the second most common lysosomal storage disease, but looking at the data, you can tell it's not that common. And so Fabry disease, typical physical manifestations include neuropathic pain, angiokeratomas, thickened lips, bulbous nose, along with other manifestations that you can't really see, such as heat and cold intolerance, abdominal pains, diarrhea, and more. And so now I'll go on to a case which a patient where it manifested in. So the patient is a 26-year-old female referred to her primary care physician for evaluation of proteinuria, hematuria with CKD stage 1 with significant history of renal diseases in the family. On examination, she was found to have angiokeratomas in the preumbilical regions. She also had complaints of tingling/pain in her hands and feet, along with episodes of extreme heat and excessive sweating. Her baseline serum creatinine was 0.5 to 0.8 milligrams per deciliter. And upon genetic testing, she was noted to be a heterozygous carrier for Fabry disease. Enzyme replacement therapy with a focus on the need for blood pressure control, metabolic derangements, lipid and diabetic control, avoidance of nephrotoxic drugs, and also education about the options of renal replacement therapy in the future was suggested to the patient. And signs and symptoms suggesting major organ involvement, warranty initiation of ERT in the symptomatic female included neuropathic pain, pain crises, Fabry disease neuropathy, proteinuria, albuminuria, not attributable to other causes, and also evidence of renal impairment. And comprehensive, timely treatment of adult patients with Fabry disease should be directed towards prevention of progressive to irreversible tissue damage and organ failure. And in conclusion, it was recommended that ERT should be initiated as early as possible in female carriers with significant disease because of risk of cardiac, cerebrovascular, and neurological complications. Thank you.
Very good. The next person is Adi Pandya.
So hello, my name is Adi Pandya. I'm a senior at Herrick's High School in New York, and my study was on acute kidney injury in pediatric patients, which was found through the analysis of FIS database. So for AKI, it's a very common complication among hospitalized children and is defined as an abrupt decline in renal function indicated by an increase in creatinine clearance and or decrease in urine output over a specified period of time. Additionally, the worldwide incidence of AKI for children ranges from anywhere from 19.3 to 24.1%, and mortality is between 30 and 50%. So the objective for this study was to see both pediatric AKI and non-AKI patients across the United States and to identify the epidemiology such as prevalence of mortality and risk factors associated with AKI. So our overall methodology, a retrospective study was done. And like I mentioned before, it was to identify the epidemiology. We went through the FIS database and collected data based on 9 variables, which was analyzed through multivariate analysis. What we found was that for the cost-based CMI was 1.08, indicating that the cost for AKI hospitalization was 8% higher than usual, and cost of typical hospitalization at 49 hospital cities. We also noticed that for mortality rate for AKI was 0.44%, and the average length of stay per AKI case was 6.2 days. And adjusted charges were $72,460. So despite the numerous studies we went through, there were no validated medications or therapies which can reverse or mitigate AKI after a patient has developed it. In children, some medications have shown promise. However, consistent benefits haven't been seen from the controlled trials for these treatments. So given the limited number of therapeutic options, there has been an attempt to identify patients for the risk of AKI at earlier methods, and which is why the study was done, because to see the average length of stay, the other comorbidities that are associated with the patients, we can assess if there is an earlier disease or different onset that can help be targeted to prevent the AKI onset. And so the results of our analysis showed that the cost of AKI hospitalization relative to cost of typical hospitalization is 8% higher, and therefore we should look at why there is such a drastic increase to see if there is something that can be done to prevent AKI onset a lot earlier in pediatric patients. Thank you.
Next person is Anu Khanda. Vigna said Anu Khanda.
Yeah. Yep. All right. So hi, I'm Sim Khanda. I'm a med student at NeoMed. So I did a case presentation on a patient with recurrent rhabdomyolysis. Alpha-methyl alkyl-CoA rasmatase, it's an enzyme involved in fatty acid metabolism. And there's a deficiency, which is a rare disorder, and I chose to explore it in a patient with it. This rare disorder presents with variable phenotype ranging from cholecystitis to late onset sensory motor neuropathy. There's been little to no data collected on these rare cases, and so I decided to kind of report on it. So my aim in this presentation is to give a little bit about the patient history with this deficiency, as well as physical findings, laboratory values, and then how we went about in treating it. And we hope by doing this will kind of spur more research into this and to explore better therapies, better medications, and just teach and how to deal with these populations. So more on the case. It was a 33-year-old female with a history of depression, presenting with complaints of acute diffuse proximal muscle aching. She recently was started on the antidepressant sertraline. And it was also noted that in the past, she's also had similar episodes of this muscle pain when she was put on fluoxetine and bupropion. However, it also went away after discontinuation of these medications. So when she came in with these problems, her laboratory results showed a significantly elevated creatinine kinase level of 12,769 units per liter. And she also had elevated inflammatory markers. Due to the muscle progressive weakness and the pain, we chose to do an electromyography, and it showed chronic proximal myopathy. After doing myositis-specific autoantibodies, including anti-Jo1, most of those panels came back negative. So we decided to do a muscle biopsy, and it was consistent with rhabdomyolysis. Oh, so because of that, we did genetic testing, and we found pristanic acid and bile acid studies to show the AMACR deficiency. So, and then we also kind of correlated it with the medications. And so we hope that by basically giving light to this future studies can focus on larger populations and compile a list of triggers that we can prevent such problems in the future.
Very good. Next is Prem Prakash Kushwala.
So my presentation is involvement of solid carrier proteins involved in a prostate cancer recurrence. So actually prostate cancer is the second leading cause of the cancer-related mortality among the US, among in men. And after additive therapy, it is a commonly caused that castrate-resistant prostate cancer. So recently, in my lab, the transcriptomic analysis was done, and we found that the cell C overexpression and its obligation related to cancer recurrence. So, however, its molecular mechanism is unknown in regarding of metabolism, how it causes resistance. So to achieve this, we perform several assays such as cell proliferation, means how this affect on cell proliferation, cell migration, because migration is a major problem in recurrence also. And we did some of the protein expression and the ELISA. We quantified some of the mechanism related protein assay. So we did, and we also did the cell cycle assay. So all these assays we perform in the knockdown cells. Actually, we did this knockdown of C4-2B enzalutamide resistance. So we have prepared the C4-2B enzalutamide resistance, and we treated for 6 months at a concentration of 5 micromolar. So after this, we knocked down with these two. We targeted, actually, we found that SLC25A17 and SLC26A6, 27A6, both were overexpressed. That's why we targeted these two proteins, and we knocked down this, and then we did the several assays. So in the cell cycle, we found that after this knockdown of these two SLCs, we found that that cell cycle is going to be G1 as arrest. And apart from this, we also checked this migration potential. So we found that the knockdown of these two, this migration was inhibited. And in the same knockdown cells, we also did the several protein Western blot analysis of the metabolic as well as the mechanism related fatty acid mechanism related protein expressions, and we found the expected result that these two SLCs are involved in the proliferation and recurrence of the prostate cancer. So in conclusion, we can say that this SLCs 25A17, SLC 27A6 may be a therapeutic target for the castrate-resistant prostate cancer cells. And some of the, in terms of clinical application, our research finding SLC, these two maybe serve as a therapeutic target for prostate cancer patients. Thank you.
Next is Snehal Chelkamari.
Yes, we can see. My name is Snehal Chelkamari. I'm a student at Denmark High School in Georgia, and I'll be giving a presentation on chronic metabolic acidosis and its adverse effects in CKD and bone density. Okay, so metabolic acidosis in the setting of CKD is the buildup of acid in the blood due to impaired excretion of bicarbonate due to worsening renal function. And the prevalence of metabolic acidosis increases in later stages of CKD as kidney function declines, and it's seen over 30% of stage 4 and 5 CKD patients. Metabolic acidosis has been shown to have harmful effects throughout the body, one of which is bone degradation associated with bone mineral disorder. And the pathophysiology of BMD is complex, and our understanding of it is evolving. A deeper understanding of BMD can lead to reliable treatments to prevent underlying conditions in the later stages of CKD, such as hypocalcemia. And so the methodology for this study was a retrospective literature review of chronic metabolic acidosis in patients with CKD irrespective of age and gender. And our study variables were patient demographics, interventions, in-grip strength, bone mass density, BMI, and several other biomarkers. And the data regarding metabolic acidosis in patients with CKD, irrespective of age and gender, is recorded, and data analysis will follow. And so, since we don't have our data analysis yet, our preliminary results has shown that roughly only 2.7% of patients with CKD stages 2 to 4 received alkali therapy to treat their metabolic acidosis. And chronic metabolic acidosis adversely impacts the musculoskeletal system, especially muscle strength. And insulin resistance is induced in CKD patients with metabolic acidosis, as they need to release insulin at higher than normal levels to inhibit proteolysis in fed states. And what we know thus far on this topic is that low levels of serum bicarbonate is linked to lower BMD. And a study using nationally representative database of hemodialysis patients showed strong associations between serum phosphorus and calcium and an increased risk of death. And further research in the form of double-blinded placebo-controlled randomized control trials is needed to corroborate current data. Additionally, research should be focused on establishing new recommendations to supplement current guidelines in that the alkali therapy is selectively applied. Thank you.
Next is Rita Deshpande.
Good afternoon, everybody. What I'm looking to present here is a paper on pediatric atypical hemolytic uremic syndrome advances. What we sought out to study were the advances over the past 20 years, focusing on the changes in the genetic variants, the pathophysiology, the triggers, and the manifestations affecting the atypical hemolytic uremic syndrome. The genetic variants in complement regulatory proteins accounted for about 50 to 60% of all the cases. And hence, we realized the recommendations of genetic testing in patients who have at least 2 family members diagnosed with AHUS within the last 6 months is essential. In addition to that, we found interesting non-complement regulatory proteins associated with the disease, that is the diacylglycerol mutations. The purpose of the study was to investigate the clinical nature of AHUS in order to focus on the triggers and the novel therapeutic options. The triggers pertaining to the disease, what we realized were the respiratory and the bacterial infections, chemotherapy, and even lupus, the infectious being the most of it. We then went on to find the therapeutic interventions because in the past, it has been primarily plasma exchange or infusion and eculizumab. But now we studied the different drugs which focus on complement-mediated diseases, and they showed potential in AHUS as well. We already know that AHUS induces multiple organ damage due to ischemia downstream, which occludes the blood vessels and causes the extra-renal manifestations. We then saw that there are recent reports which emphasize the relationship of anti-complement factor H antibodies, anti-complement factor 1 autoantibodies, and diacylglycerol kinase epsilon, all of these associated with AHUS. There have been several reports of a bidirectional relationship of COVID-19 along with the AHUS because of the common complement-mediated pathophysiology as well. COVID-19 somehow was a trigger even in patients in the presence of pathogenic CFH variants. and there has been reports of hepatitis B. Thank you.
Next is Arul Mehta.
Okay, hello everyone, I'm Arul Mehta, and today I'll be presenting on the quantitative MRI assessments of kidney disease progression in patients with autosomal recessive polycystic kidney disease. So ARPKD is a rare inherited childhood condition where patients can develop kidney disease resulting in renal failure. And this disease is an important cause of morbidity and mortality in children with chronic kidney disease and affects 1 in every 20,000 children. There are currently no treatment options for this disease due to a lack of sensitive measures, and the rarity of the disease allows us to take only small sample sizes of the population as well. So we would need a better assessment of disease progression to support clinical trials. And in the current study, we evaluated the relationship between T1 and T2 MRF-based imaging parameters with clinical assessments of EGFR, which is the gold standard used by nephrologists to test levels of kidney function in ARPKD subjects. So our hypothesis was to see if quantitative MRI techniques were used to assess kidney disease progression in ARPKD. So we compared novel MRI assessments with established clinical measures of kidney disease progression in subjects with ARPKD to test whether there's a correlation between T1 and T2 relaxation times and EGFR in ARPKD subjects. And then we were also trying to observe whether magnetic resonance fingerprinting is repeatable between consecutive days as well. So 7 subjects with ARPKD between the age range of 6 through 22 were scanned. They were scanned on the Siemens 3T MRI scanner utilizing novel MRF technology to simultaneously generate novel kidney T1 and T2 maps in 15 seconds per imaging slice with no sedation or injectable contrast agent. And we found that the T1 and T2 values were significantly higher in ARPKD patients than healthy volunteers. And we then plotted the values from the scanner and verified that MRF is repeatable. And the values we received on day 1 and day 2 indicated that there's less than a 4% statistical difference for T1 values, and there's less than a 3% statistical difference for T2 values, indicating that MRF is repeatable. And then here we see in the figures that the mean kidney T2 values demonstrated a significant negative correlation with EGFR, and the mean kidney T1 also shows a strong negative correlation, but have not yet reached significance. So this is the first study to establish a relationship between MRI-derived imaging biomarkers and kidney function in ARPKD subjects. And despite the small cohort, the data clearly demonstrates that mean T1 and T2 both increase with declining EGFR. And we were also able to display that MRF is repeatable and non-invasive since it offers 15 seconds per imaging slice with no sedation or injectable contrast agent. These important findings suggest that MRF-based T1 and T2 mapping may provide a safe and reproducible measure of kidney disease severity in ARPKD for future clinical trials. Thank you.
Very good. Next is Siddharth Singh.
Hi, my name is Siddharth Singh, and I'm a medical student at Northeast Ohio Medical University. And today I'm presenting a literature review on cystic diseases of the kidney, focusing on research that has developed taking the process from bench to the bedside. And essentially, this all started with the exploration into the ORPK mouse model, where they had a double knockout of the PKD1 gene, which induced the phenotype that led to polycystic kidney disease, as seen in humans. Further exploration into this mouse model showed how that the PKD1 gene product localized to the cilia, and that led to a boost of research that showed that other cystic kidney diseases also have proteins which localize to this. So essentially, recent data is providing compelling evidence that inherited cystic kidney disease is linked to the function and misfunction of the cilia, particularly in the embryonic node as well as in the epithelial renal tubules. Now, kidney function normally depends on flow of produced urine through the tubules, and this is sensed by cilia. So normally, this causes an increased regulation of calcium-dependent channels. However, disruptions due to mutations can lead to defects in the channel and eventually polycystic kidney disease. Now, signaling pathways, at least on the biochemistry side, which have been linked to cilia and furthermore cell proliferation, is largely unknown. However, we know that the JAK-STAT, Wnt, beta-catenin, PKC, CAMP, G-protein pathways, which are all dependent on calcium signaling, are involved. Now, models using these non-biased forward genetic screening for cystic kidney disease mutants in non-humans have found that this is associated with abnormal cytogenesis. By further analyzing these mutant phenotypes, we can link cilia and improper cilia function to cellular proliferation and the development of cysts. Now, the chart in the middle demonstrates a classification of cystic kidney diseases according to Foster and Ostenon. Now, some of these fall into genetic cases, which is the main ones we'll be looking at. However, there are other cystic kidney diseases, sporadic and miscellaneous, which do comprise a portion of cystic kidney disease, however much smaller. Now, within these genetic models that we have developed for cystic kidney diseases, we can use this to explain how some of these cystic kidney diseases are inherited. For example, autosomal dominant polycystic kidney disease is inherited in an autosomal dominant manner. However, it turns out that only one inherited mutation in the child is significant enough to induce the later polycystic kidney disease expression. And this happens as a de novo mutation and further in life. Now, however, a lot of other Mendelian inheritance patterns cannot always be used to demonstrate how these pathologies develop. So, for example, we have Bardet-Biedl syndrome, which is where we can see anticipation, where children are often found to show the disease much earlier than the parents. So, in essence, ciliopathies are an emerging framework in which we can use to describe renal cystic disease. And further forays into this combining patient care can help us further understand how these cystic diseases develop and how they're presenting, and further work on the treatment. Thank you for having me. I'm done, so the next presenter can go.
Great. Last but not least, Rohit Jain.
Hello all, my name is Rohit Jain, and my project was on systematic review in inborn errors of metabolism and renal replacement therapy of neonates and pediatrics. Our main goal was to focus on how physicians treat patients, neonates under the age of 18 with IEMs, which are inborn errors of metabolism. Initial presentation of IEM is hypotonia, irritability, somnolence, and metabolic acidosis. There's also different presentations such as poor feeding, refusal to feed, vomiting, and failure to thrive. Our main focus was trying to see which types of therapy best helped best treated the patients. Our population study was neonates and pediatrics with IEM under the age of 18. We used 28 studies and used test results of over 1,580 subjects. And we found that the main disorders were urea-cycle disorders and organic acidurias. And we also found that the main ways that physicians used to treat these patients effectively was hemodialysis with 67% and continuous renal replacement therapy at 29%. Overall, as the numbers show, hemodialysis was the most effective and most used method of treating neonates with IEM. However, continuous renal replacement therapy, CRRT, was shown to decrease plasma ammonium levels with less risk of hemodialysis instability. There's also the case that shows that appropriate nutritional support also helps protein catabolism, which can also cure the patients and neonates better and without these treatment methods. There's also the fact that the rapid clearance of plasma ammonia levels in continuous renal replacement therapy is used more often to treat severe hyperammonia, which is why it may not be used as much because most of the patients may not have such a severe disease. Thank you.
Very good. We had one person who could not present due to technical issues. Yalagiri, you want to give it a shot again?
Yeah, let me give it one more shot. Hi, everyone. My name is Keval Yaragiri. I am a fourth-year medical student at Northeast Ohio Medical University. And today I'll be presenting a pet project of mine for my research here at the National Institutes of Health, inflammatory biomarkers as a prognostic scoring model for peritoneal malignant mesothelioma. Special thanks to my statistician, Seth Steinberg, and my mentor, Dr. Rafi Hassan. So malignant mesothelioma, it's an aggressive tumor that most commonly originates in the pleura or the peritoneum, and it's usually induced by a chronic inflammatory process such as asbestos exposure. Asbestos exposure usually has a 20 to 40-year refractory period, so the tumor will arise in the 50 to 70 age group the most often. There are also increasing number of cases in around 30 to 40-year-olds. Most of these patients also have high-dose radiation exposure during childhood, say for a case of pediatric leukemia. The issue with malignant mesothelioma is that it's very hard to detect in an early stage, usually presents in an advanced stage, and at that point has a very poor prognosis. Median survival is only 12 months. There are very few diagnostic or prognostic markers available, and the only currently FDA-approved diagnostic marker is soluble mesothelin-related peptide as part of the Mesomark assay. For this study, we wanted to look at inflammatory biomarkers and see if they could predict prognosis, which would better help us be informed as to whether we want to take a more palliative approach towards the tumor or take a more aggressive treatment with radiation, surgery, and even some immunotherapies. As part of this protocol, we extracted 448 patients from our lab's natural history study, of whom 159 met our inclusion criteria of having mesothelioma of peritoneal origin and of having inflammatory biomarker values within 7 days of protocol consent date. Of these 159 patients, the average age of diagnosis was 50.8, and the average survival from that point was 1,574 days, so approximately 4 years. We looked at 4 separate inflammatory biomarkers: MPF, C-reactive protein, CA125, and fibrinogen, and then used Kaplan-Meier curves, as you can see on the right side here, to look at the survival benefits based on their categorization of inflammatory biomarker value. The blue signifies the bottom 25% of biomarker values, the green signifies the top 25%. And as you can see on the charts to the right, patients in the bottom 25% had significantly better survival over 2 years, 4 years, 6, and 8, compared to patients with the top 25% of biomarker values. We used the Cox regression model to combine the data for MPF and C-reactive protein and created a joint evaluation survival curve that you can see in the bottom right. Thank you very much. Hopefully this study will be used going forward.
Very good. We are glad we could accommodate this. So with this, I think it is the end of our session. Good to hear from everyone. Good luck for your careers, and see you hopefully next year. Bye-bye.
Welcome, everybody. I'm Dr. Mona Gupta, one of the co-chairs of this research showcase, and we appreciate all of you joining to get here today. Looking forward to an exciting presentation from all of you. There are some ground rules I want to start to let you know. So when you start presenting your posters, you will be able to see the timer when you're presenting. And you will have 3 minutes to present, and you will be muted after 3 minutes. So please time and pace yourself accordingly. And also please change your screen to gallery view. And you all have the list as to when is your time to present. So if you can have your poster ready prior to your designated time, that would be great. Just pull it up so it's easy for you to share. In the interest of time, respecting everybody's time, and also so we finish on time, I will start. Amrit, please go ahead and start.
Oh, yes. Okay. I will make mine a little quick since we're already slightly behind. But my project was on the systematic review of atypical hemolytic uremic syndrome biomarkers. Basically, this is a chronic and life-threatening disease arising from genetic abnormalities, resulting in uncontrolled activation of the alternative pathway. Also, fun fact, if there's anyone with this disease in Northeast Ohio or Western Pennsylvania, Dr. Rena is probably going to get them. The prevalence is about 1 in a few million. So with this, diagnosing HUS can also be very challenging due to its poor penetrance and ambiguous clinical presentation. Genetic variants only account for 50 to 60% of all patients. The other 30 to 50%, they don't have an identifiable mutation yet, which brings us to the purpose of this project. There is no gold standard for the diagnosis of HUS yet. So what they typically do is use gene panel testing. But because this doesn't work for 30 to 50% of individuals, we're trying to make a serum test. So the goal would be to make a quick and easy to use blood test that would narrow down individuals who would have AHUS. So the way we went about this is that we went through a lot of cases of AHUS and looked at the complement biomarkers that were assessed in their serum levels, as well as renal biomarkers, mutational markers, and coagulation biomarkers. And the results of that showed that AHUS subjects, compared to the average individual, had lower C3, CH50, AH50, and factor B levels, as well as higher C5a, C5b9, and factor B and D dimer levels. So again, the end goal would be to narrow down this a little more and make it so that standard practice would show a simple serum test would narrow down AHUS compared to waiting a few days to weeks for genetic tests to come back. And that leaves 1 minute, and I'll end it there since we're slightly behind already.
Thank you very much, Amrit. Our next presenter is Nikita Kumar.
She is not going to be here today, so we're going to go to the next one if that's okay.
Sure. Next is Harsha Sanaka.
All right. Good afternoon, all. Thank you for providing me with the opportunity to present today. Today, I'll be talking about stress-induced changes in sample on mice, a murine model of Crohn's disease. So Crohn's disease is a chronic inflammatory condition of the gastrointestinal tract, and studies have shown that psychological stress is a significant risk factor for symptomatic flares of Crohn's disease, indicating the existence of a brain-gut axis. The SAMP mouse model is an ideal candidate for exploring this axis because it develops spontaneous Crohn's disease like ileitis. Preliminary research has showed that SAMP mice develop colonic tertiary lymphoid organs, or TLOs, which are essentially masses of lymphocytes in response to restrained stress. This was a surprising finding considering SAMP mice have previously never had development of Crohn's disease in the colon. Therefore, we want to figure out how exactly SAMP mice could respond to stress and colonic insight via dextran sodium sulfate, and also known as DSS, and whether the presence of TLOs played any role. So 40 SAMP mice were split into an experimental group, stressed, and a control group, unstressed. Restrained stress was performed on the experimental group. They were placed in a conical tube for 3 hours a day over 8 weeks. After that, mice were further subdivided and subsequently treated with 3% DSS for 7 days, followed by a recovery period of 14 days. On days 8 and 21 of the DSS trial, colonoscopies were performed on the mice up to the splenic flexure. Inflammation was evaluated by a colonoscopy score, intestinal tissue was evaluated by an inflammatory score from histology, stool IgA levels were quantified, and mesenteric lymph node composition was assessed with fluorescence-activated single-cell sorting. Surprisingly, on colonoscopy in Figure 3, we see that the colons of the unstressed mice look much worse than those of stressed mice. There's more frequent ulceration, even some bleeding, and the mucosa is more inflamed, which explains low vein visibility. In Figure 1, we see that stressed mice had significantly better colonoscopy scores and stressed mice had better colonic inflammatory scores following DSS. As shown in Figure 2, stress resulted in decreased levels of IgA only following DSS administration. Figures 4 and 5 showed the inflammatory cell profile of the mesenteric lymph nodes, which remained largely unchanged despite stress. All in all, the protective effect of stress against DSS in SAMP mice is definitely an interesting result, especially given the lack of changes to MLN cell profile and reduction in stool IgA levels. It seems that TLOs, or these tertiary lymphoid organs, are correlated with this protective effect of stress, and thus future steps are being taken to elucidate the nature of TLOs. For instance, we'll cross SAMP mice with IL-23 receptor knockout mice, which will hypothetically have no TLOs, and see whether there is still a protective barrier against DSS colonic insult. Thank you.
Thank you, Harsha. That was great. Amrit, do you have somebody who's going to be speaking and presenting in place of Nikita? We can't hear you, Amrit.
Oh, sorry. Okay, yes, next would be Nina. She was supposed to go earlier.
Hi, everybody. I'm Nina. I'm a junior at Emory University, and one of the projects that I was working on this summer was about acute liver failure, which refers to the development of encephalopathy and synthetic dysfunction when there isn't a pre-existing disease, liver disease involved. And so essentially what previous research has shown is that acute kidney injury in pediatric ALF can actually be a comorbidity in about 40 to 85% of patients with ALF. And although it's very heavily studied in adults, it's not well studied in pediatrics. And so that was really the objective of this paper. If I zoom out, is that to study AKI in pediatric ALF. And the way that we did this was through a systematic review of pediatric patients with either acute or chronic liver failure who had previously received renal replacement therapy of any form. We looked at a variety of study variables, including mortality, survival, transplantation, and we also included data from about 8 studies, including retrospective studies and case control studies. So if we look up here in the results section, we can see that what we found of the cohort of patients that we were studying is that about 36% of pediatric patients with ALF had acute kidney injury, and of this subset of the population, about 29% or just less than 29% had pediatric, so they had died. So pediatric mortality, which is quite a high number. And so this paper really focuses on how we can better combat pediatric AKI in ALF and discuss treatment and management methods, including conservative management, such as one of the findings that we found is that albumin infusions actually have the potential to be effective in volume expansion in AKI. We also looked at different KRT indicators as right here, which show the suggested conditions in order to start KRT, as well as showing that cystatin C estimates of eGFR are the most accurate when dealing with pediatric AKI in ALF. We also looked at things like vascular access, for example, looking at the right internal jugular vein as the ideal catheter insertion, as well as different modalities of KRT, such as the use of CKRT instead of IHD. We also identified that the CKRT machines are actually able to modify dialysis flow rates according to the child's weight, which was quite interesting. And looking at a variety of different things, we also looked at the initiation, duration, and monitoring of treatment. In all, we are able to better understand through this project pediatric acute kidney injury in ALF patients. Thank you.
Thank you, Nia. That was great presentation. Our next presenter is Anuradha Kanaparthi.
Hi, everyone. My name is Anu Kanaparthi, and I'm a 4th-year medical student at Neomed. My project is regarding postoperative nausea and vomiting, or PONV, in patients undergoing surgery during pregnancy. So PONV itself is a common but unpleasant side effect of general anesthesia. And typically it leads to negative outcomes after surgery, such as patient dissatisfaction, prolonged hospital stays, PACU stays, and increased healthcare costs as a result. Essentially, the prophylactic treatment of the patients who are at high risk can prevent PONV and lead to decreased negative postoperative outcomes after. And to treat patients at high risk, guidelines identify risk factors that may contribute to the development of PONV, such as young age, female gender, non-smoking status, and postoperative or perioperative opioid use. However, limited studies exist that actually explore PONV in the gravid patient population who undergo surgery during pregnancy itself. In this study, we sought to identify, one, if pregnancy is in and of itself a risk factor to developing PONV after surgery, and whether PONV prophylaxis in pregnant patients is adequately administered. This was a retrospective case control study with 1-to-2 matching conducted at an academic medical center with a high volume surgical practice. Essentially, the EMRs and perioperative records were abstracted for predisposing baseline risk factors and characteristics that may increase the risk of PONV. PONV documentation, as noted by nursing and providers, or use of rescue antiemetics. Further, the duration of PACU stay and length of hospitalization were also noted. Overall, 240 patients underwent non-obstetric procedures during the 10-year span that we looked at. And summarized from all of the tables, there was a greater incidence of PONV with an adjusted odds ratio of 1.69. And the number of all prophylactic antiemetics administered
were less in these gravid populations significantly. Overall, perioperative outcomes noted a longer length of stay both in the PACU and also in the hospital as well. And this greater risk of PONV may have been due to the pre-existing and underlying nausea and vomiting of pregnancy, as well as the physiological changes during pregnancy as well, such as the uterus compressing upon the intra-abdominal space. But further, there was also a trend that was insignificant, but still a trend towards using more opioids in the gravid patients as well, which may have contributed. Further, the decreased number of prophylactic antiemetics that were administered could be due to, one, the provider hesitancy due to fear of effects on the fetus, as well as the patients may have themselves declined the medications as well. Overall, we noted that the risk of PONV is due to many factors, and more studies are still required in the gravid population to fully assess the risk of PONV as well. Thank you.
Thank you, Naradha. That was great presentation, another nice presentation. Our next presenter is Prajit Kublal. I'm sorry if I mispronounced it. Is that how you pronounce your name? Kublal? Is that a right pronunciation?
Yes, hi, I'm Prajit Kublal.
Kublal, okay. Yes, please go ahead.
Okay, my name is Prajit Kublal. I'm a fourth-year medical student from NeoMed as well. My study was on assessing the need for peritoneal dialysis in neonatal acute kidney injury, or AKI, from the prospective Tinker study. For the introduction, that despite improvement in the care of critically ill neonates, AKI is commonly faced in infants, especially those admitted to the NICU, with an incidence of 15 to 70% across various studies. The AWAKEN study found an increased risk up to 48% in preterm infants born between 22 and 29 weeks of gestation. There's also additional contributors such as inborn errors of metabolism and previous need for surgery. First-line treatment for AKI in this population is typically conservative, followed by kidney replacement therapy, or KRT. The AWAKEN study, which this is based off of as well, showed 4.1% of neonates with AKI undergo KRT, while in developing countries, 42.3% of neonates undergo peritoneal dialysis. So the objective of this study was to identify variables influencing the requirements of PD as opposed to KRT among neonates with AKI, and then to compare the outcomes of neonates with AKI who do or do not receive peritoneal dialysis. This was a prospective study derived from the Tinker database, and neonates, for those who don't know, are defined as recently born babies less than 28 days of age. The results from this study showed that 1,600 neonates were included in the study, of which only 491 had AKI defined by the KDIGO criteria. The median duration of stay was 10 days. Of these 491 subjects, only 9% received peritoneal dialysis, and they found that of those receiving PD, there is a lower median APGAR score, which is a poor prognostic factor at the time of birth, along with lower urine output and hemoglobin, while those receiving PD had higher serum urea concentrations and serum creatinine during their first 12 hours in the NICU. So drawing to the discussion, the significant differences were these lower and higher prognostic factors, which draws to figure 1, comparing the duration of stay in the NICU. For those receiving peritoneal dialysis, there was a shorter median duration of stay, but a significantly higher mortality rate. When excluding neonates who died, there was no statistically significant difference between these, however. Some underlying characteristics indicative of future peritoneal dialysis use is indicated in figure 2, which include maternal severe peripartum events and resuscitation in the delivery room. So from the study, while it did not record peritoneal dialysis related complications, it does inquire about the use of PD in these lower income countries, and also the adoption of universal dialysis support machines to enhance the long-term recovery of neonates with AKI, both in low income and high income countries. Thank you.
Thank you, Prajit. Our next presenter is Ritik Halra.
Hi, everybody. Today I'm going to be discussing the correlation between obesity and chronic kidney disease in children and adolescent populations. So in the United States, obesity has reached epidemic proportions and remains a very relevant health problem today. As of 2018, nearly 20%, 19.3 million children and adolescents are either overweight or obese. In fact, according to the World Health Organization, the rate of those overweight and obese has risen significantly from 4% in just 1975 to nearly 18% in 2016. However, recent estimates have actually shown that implicate obesity as being the cause of between 24 and 33% of all renal disease. And although obesity has been linked to the increasing incidence of chronic kidney disease, or CKD, in children and adolescents, this correlation still hasn't been fully elucidated. So the objective of our study assessed the effect of obesity on the development of renal disease, specifically CKD, among global child and adolescent populations. In fact, we also assessed risk factors such as CKD treatments and bariatric surgery as well. The design of our study conducted a retrospective literature review on the incidence of both obesity and CKD in the pediatric and adolescent populations. We looked at pediatric and adolescent population patients under the age of 18 years old who had both obesity and CKD. And we evaluated comorbidities such as metabolic syndrome, diabetes, cholesterol, heart disease, blood pressure, CKD management and progression, as well as other co-interventions as well. Our results showed an aggravated prevalence of microalbuminuria, hypertension, low HDL, proteinuria, insulin resistance, uric acid, macroalbuminuria, and HOMA-R index as well. In our conclusion and discussion section, we talked a lot about how it is evident that among children and adolescent population, obesity is indeed a potent risk factor for the development of renal disease. And obesity increases the risk of developing major risk factors of CKD as well, thus having a direct impact on the development of CKD. Two things we wanted to note was one, that BMI unfortunately is not the most accurate tool to quantify obesity, as it doesn't account for or differentiate body fat and muscle. And several of the studies that we looked at between 2005 and 2017 did not account for certain factors such as height, sex, ethnicity, muscle mass, and sexual maturation as well. We also looked into bariatric surgery as a treatment plan for CKD patients who are obese as well. And it is quite clear that obesity is in fact a preventable risk factor, either through surgical means or lifestyle changes. So we looked into lifestyle changes that could be assessed, as well as bariatric surgery that could be assessed as well. And we came to the conclusion that while information is scarce, the correlation is quite interconnected between the two. Thank you.
Great presentation, Preeti. Our next presenter is Ahmad Houri.
So my name is Ahmad Houri. I'm going to talk today about sustained low efficiency dialysis, which I'm going to be referred as SLAT during this presentation, as an alternative way to other kidney replacement therapy in PICU. So as a little bit of starting with background, critically ill children that require admission to PICU are at an increased risk of developing AKI. And it was also found that 1/3 of PICU patients, it was actually found that 1/3 of PICU patients who develop AKI have 4 times more likely risk to die from AKI. That's why a kidney replacement therapy is needed in PICU. It's a systematic review of the literature. I gathered information from PubMed, Google Scholar, and a lot of search engine. Literature found that SLAD is actually a type of knee replacement therapy that's used in developing countries widely. It was found that children in PICU require low blood flow when kidney replacement therapy is needed. That's why SLAD is very important. SLAD is given between 8 to 12 hours, and it gives a sustained low blood flow. It's determined that SLAD would be given depending on the weight of the children and whether they have hyperkalemia, azotemia, edema, and oliguria as indication for SLAD. After gathering the results, it's shown that SLAD can correct metabolic acidosis, hyperkalemia, blood pressure, and the most important thing, it can decrease edema. So it will decrease the pressure put on the lungs and the heart. Overall, it was found that it's very important to use SLAD, and it could be a feasible method, and many children who in PICU who used SLAD regained normal kidney function and successful recovery after SLAD. Thank you.
Thank you, Ahmed. That was great presentation, nicely presented. Next presenter is Manasa Malachuri.
So my name is Manasa Melachuri, and I'm an M4 at Northeast Ohio Medical University. And I looked at pediatric hypertension and its effect on cardiovascular outcomes. We all know hypertension is a very common disease, and it affects nearly 3.5% of children and adolescents in the United States. Hypertension affects many organ systems, and specifically the cardiovascular system. We wanted to assess quantitatively how the heart is affected in the pediatric population. Specifically, we looked at left ventricular mass index, left ventricular hypertrophy, carotid intima media thickness, uric acid levels, and aortic stiffness. So what we did was a literature search on pediatric hypertension and found 67 studies that looked at 189,000 children. We then extracted data on each of the parameters that we were measuring and found that in the normotensive cohort, in children with not hypertension, they have a lower systolic blood pressure, diastolic blood pressure, mean arterial pressure, and pulse pressure. And we found that the hypertensive cohort had a significantly increased value in all of these. We also went on to look at left ventricular mass index and found that in the normotensive cohort, the left ventricular mass index was 30.1, and in the hypertensive cohort, this went up to an average of 39.3. The next assessment that we did was the carotid intima media thickness. And here we had similar results, with the hypertensive cohort having a significantly elevated carotid intima media thickness at 0.55, and the control cohort significantly less at 0.49. So this study quantitatively assessed specific parameters of cardiovascular measures in children and found that there are detrimental effects with hypertension, and it's imperative to identify and intervene at an early age. Thank you.
Okay, next we'll do Isabella Malpi. I hope I said that right.
All right. So let's see. So I'm a third-year medical student at Neomed, and for my project, I'm talking about acute kidney injury in COVID-19 pediatric patients in our analysis of the virtual pediatric systems data. So we're all aware of how detrimental COVID-19 has been to the world, and millions of people are affected, including children. And while it may be noted that children tend not to have as severe disease as in adults, children still do get very ill from COVID-19, and this is often overlooked. One manifestation of COVID-19 in children is acute kidney injury, or AKI, and despite extensive research into acute kidney injury in adults, research into the epidemiology, associated risk factors, treatments, and mortality of AKI in pediatric COVID-19 patients is pretty understudied. This is why the study I'm presenting today is aimed at assessing AKI incidence, associated risk factors, treatments such as KRT, and associated mortality rates among COVID-19 pediatric patients in the pediatric ICU using the VPS data. So this is a retrospective analysis of 2,546 COVID-19 pediatric patients as defined by being less than 21 years old who were admitted to the ICU in North America. And this data analysis was conducted between January 1st, 2020 and June 30th, 2021. So jumping to the results, out of a total of 2,546 of the COVID-19 patients, 10.8% or 274 were diagnosed with AKI, and there were significantly higher continuous and categorical outcomes in the AKI subset compared to the non-AKI cohort, which included length of stay at hospital, PIM2 and PIM3 probability of death, mortality, airway and respiratory support, and cardiorespiratory support, and kidney support and vascular access. And many pertinent clinical lab values were also higher among the AKI subset, which included things like serum potassium, BUN, creatinine, and GFR. Associated comorbidities with AKI, according to the BPS database, included respiratory, cardiovascular, endocrine, and hematological comorbidities.
Additionally, as you can see in the charts, a more advanced stage of the AKI using the KDIGO guidelines was associated with worse outcomes, which kind of makes sense. So overall, based on our results, AKI among children with COVID-19 has been shown to be associated with increased risk of mortality and complication. So this is one of the first large-scale studies to analyze AKI among pediatric COVID-19 patients here in North America. So it's just a good start at looking at how serious COVID-19 can be for pediatric patients. Thank you.
Okay, thanks, Isabel. Divya, are you ready yet? Or, we can keep skipping you.
Okay, you can see. Awesome. So my name is Divya Sharma. Nice to meet you all. And I'm a fourth-year medical student at Northeast Ohio Medical.
Wait, Divya, it's not sharing yet. Oh, there it goes. Okay, you're good.
Okay, awesome. So nice to meet you all. I'm Divya Sharma. I'm a fourth-year medical student at NeoMed. And my poster is on our project titled Aspire, which is the assessment of South Asian pediatric acute kidney injury, epidemiology, and risk factors. So we wanted to show the design of our prospective study on severe pediatric AKI. So starting with the background, acute kidney injury is a significant health issue in the pediatric population. It affects almost 1/3 of all critically sick children admitted to the hospital, and the epidemiology of AKI in the pediatric population is not well defined. Additionally, resource inequality can play a large role in the incidence and outcomes of pediatric AKI. So the objectives of our study, which is currently ongoing, are to gain a better understanding of the epidemiology of AKI in the pediatric population of South Asia. We also hope to acquire data to better compare the incidence of pediatric AKI in low-resource countries compared to high-resource countries. So for our methods, this is a multi-center, multinational prospective observational study, and it includes data from 21 pediatric care centers across various South Asian countries, which are shown in Figure 1. This study will involve 30 unique variables focused on patient demographics, patient outcomes, and the etiology of AKI. And the data collection will occur via a secure patient registry between the 21 participating pediatric care centers. You can see in Figure 1, there are 21 pediatric care centers which are involved in the study, and there are 10 from India, 1 from Pakistan, 3 from Bangladesh, 2 from Sri Lanka, 1 from Myanmar, 3 from Nepal, and 1 from the Maldives. And going on to Figure 2, the workflow for our project will first involve getting data from the registries from each participating center, cleaning the data so we're following ethical research rules, and then from there creating a larger database to compile the data from each participating center. Finally, we hope to analyze the data and better treat pediatric patients with AKI. For our discussion, we want to emphasize that the Aspire study can provide valuable information on how to better prevent and treat pediatric AKI. And finally, we want to kind of emphasize how studying the epidemiology of AKI in low-resource countries will help bridge the gap in care between underdeveloped and developed countries. Thank you all.
Thanks, Divya. Next is Nikhil Datla.
Amrit, can you see the screen?
Yep, we can see it.
Awesome, thank you. Hi everyone, my name is Nikhil Datla, and I'm a fourth-year medical student at Northeast Ohio Medical University. My presentation is on cardiac metabolism in the disease of acute myocardial infarction. So, overproduced reactive oxygen species with decreased oxidative phosphorylation is the hallmark of the post-ischemic heart, which results in reperfusion-induced oxidative injury of the citric acid cycle. So during ischemia, hypoxic conditions slow down that citric acid cycle, resulting in succinate accumulation. Succinate is then rapidly oxidized through reperfusion, which then fuels the ROS overproduction and contributes to ischemia reperfusion injury. So we tested 2 hypotheses, one being that reperfusion reaccelerates the citric acid cycle to correct the succinate accumulation, and then 2, that a vicious cycle occurs caused by the excessive reactive oxygen species that can impair and downregulate the citric acid cycle plus other metabolic pathways in the post-ischemic heart. So we did a study using 9 to 10-week-old Sprague dollar rats, which we had 15 of those rats, where we subjected them to coronary ligation for 30 minutes, and then we allowed 24 hours for reperfusion. So we basically mimicked a heart attack in all 15 of these rats. And this process allowed us to closely mimic the acute MI and ischemic reperfusion injury. So then we kind of cut open the heart by cutting open the non-ischemic and the ischemic regions of the heart, and we excised the mitochondria from each section. We used a dimethyl labeling technique to illuminate key metabolic pathways. And previous data already showed that ischemic reperfusion impairs the ADP-dependent oxygen consumption rate and ATP generation via downregulation of the citric acid cycle and the fatty acid beta oxidation. However, a major finding of our study was that ischemic reperfusion injury dramatically upregulates the phosphocreatinine shuttle, which helps regenerate ATP in the cytosol. So from this, we conclude that upregulating the phosphocreatinine shuttle via increased creatinine kinase 2 serves as a feedback regulation for ischemia and reperfusion, which then can be useful for therapeutic interventions by increasing oxygenation and bioenergetics of the ischemic heart.
Okay, thanks, Nikhil. I'm not sure if Jubaida Mazumdar is here. If not, we'll skip to the next, Shiv Verma, who I don't, oh yeah, Shiv Verma's here. You can go.
Yeah, so can you see my poster?
Yes, we can see it.
Okay. Hi, my name is Shiv Verma, and I'm working at Urology Department, Case Western Reserve University. And today my poster is all about the risk of cognitive impairment in prostate cancer undergoing androgen deprivation therapy. So with reference to the previous studies, what we found is like lots of clinicians and researchers have, they had like identified that patient who is going through androgen deprivation therapy for a long period of time, they developed some kind of cognitive impairment, some kind of depressions, and sometimes Alzheimer's disease also. In one of the data published in JAMA publication, JAMA Oncology Journal, they have shown that 13% of patients who have gone through or undergoing ADT hormone therapy in prostate cancer developed some kind of neurological disease like Alzheimer and dementia. So, but lots of paper have been published, but the molecular mechanism was very limited or not known till now. So we took that initiative and tried to understand the molecular mechanism behind those impairment related with hormone therapy. So what we found is like when we compared both the database using bioinformatics analysis, we found that the cytokines expression were very high. Even the IL-17 IL-17 signaling pathway is very high. So when IL signaling pathway is very high, that tends to follow the paracrine loop, and it affects the other organ of the body, including brain. So here we identified that if we and then we analyze our data in prostate cancer cell lines treated with enzalutamide, which is one of the hormone therapy treatment used in second generation drug in prostate cancer. And we also treat brain cells with same drug. And we found that those signaling pathways and those molecules of cytokines were upregulated. So what we concluded from our results that if we use combination of drug along with enzalutamide or any hormone therapy inhibitor of IL-17RA, then that will be a good, that will be serve as a very good therapy to treat advanced stage prostate cancer. Thank you very much.
Thank you, Shiv. Next is Bhavya Sharma. Yes, we can see it.
Okay, awesome. So my name is Bhavya. I'm a fourth year medical student at NeoMed. And today I'm going to be talking about my poster titled A Trial of Therapeutic Plasma Exchange in Intramuscular Ricin Poisoning. So a brief introduction. Ricin poisoning is an exceedingly rare clinical scenario encountered in the field of toxicology. Potential routes of exposure consist of injection, inhalation, or ingestion. The ricin toxin's mechanism of action involves inhibition of protein synthesis And to our knowledge, there has been only one prior confirmed lethal case of intramuscular poisoning. Some clinical signs and symptoms of ricin poisoning include nausea, vomiting, shortness of breath, pulmonary edema, cutaneous necrosis, visceral necrosis, multi-organ failure, and sepsis. And ricin poisoning is pretty famous for being known to be extracted from castor beans. So for our case presentation, we had a 37-year-old man present to the emergency department with dyspnea, chest tightness, chills, myalgia, fatigue, and back pain. He arrived to the ED 24 hours after injecting his left antecubital area with 4 cc's of a supernatant fluid composed of mashed castor beans, acetone, and water. His vitals in the emergency room were a temperature of 99.7, blood pressure of 127/51, a pulse of 100 beats per minute, and a respiratory rate of 20 with O2 saturation of 97% on room air. On physical exam in the emergency department, he was awake, alert, and oriented in mild distress. A small circular erythema was noted on his left arm, just proximal to the antecubital fossa without necrosis. The remainder of the exam was benign. On day 1 of his admission, he had a white count of 10.2, platelets of 161,000. Urine drug screen was positive for methadone and amphetamines. He had a significant past history of multiple suicide attempts. He had a creatinine of 0.6 on day 1 of his admission, an ALT of 98, and AST of 156. The CK was elevated at approximately 1,200. Troponins were within normal limits, and his chest X-ray was normal. On day 2, his transaminitis worsened, and plasma exchange was initiated. On day 4, he developed acute hypoxic respiratory failure with chest X-ray demonstrating bilateral pulmonary vascular congestion and bilateral pleural effusion. Empiric vancomycin and piperacillin tazobactam were initiated on day 4. On day 5, he required endotracheal intubation due to his respiratory distress and had a negative infectious workup. On days 6 through 9, he developed acute renal failure with progression to multi-organ system dysfunction. On day 10, his family declined to pursue further treatment, and the patient was extubated and transferred to hospice, where he passed away on day 11. So there's a paucity of published reports on attempted or completed rice injection. To our knowledge, there have only been 3 documented incidents of sublethal poisoning and 1 lethal poisoning after IM rice injection. Renal failure has been observed in these patients, but there is a lack of documented evidence on appropriate management. We report a trial of plasma exchange in an individual who injected castor bean extract intramuscularly. We believe our report provides valuable insight in the management of acute ricin poisoning.
Thanks, Bhavya. Next is Satya Areti.
Hey, I'm Satya. I'm a first-year Med Peds resident at Case Western. I'm presenting a case report on macrophage activation syndrome. So what is it? It's a form of hemophagocytic lymphohistiocytosis, which is a condition defined by overactive immune response that causes tissue destruction and excessive inflammation. And it's been seen in a lot of rheumatologic conditions, mainly juvenile idiopathic arthritis and lupus. Our case was a 40-year-old obese female with lupus, gastric bypass, and non-alcoholic fatty liver disease, who was initially admitted for alcoholic hepatitis, complicated by hepatorenal syndrome due to abdominal pain, nausea, vomiting, and confusion, given the recent history of alcoholic use that she had. On labs, we saw leukocytosis, anemia, thrombocytopenia, and elevated creatinine, with a mildly elevated AST and liver steatosis on abdominal CT. So our differential for her was lupus versus hepatorenal syndrome. We weren't able to get a biopsy just due to body habitus, but then she was transferred to the MICU for shock that required intubation. Just our workup so far, our infectious workup wise, was completely negative. So we thought this was lupus that was causing the macrophage activation syndrome, since she had anemia, thrombocytopenia, liver function abnormalities, and worsening multi-organ failure. To treat her as macrophage activation syndrome, we gave her pulse dose IV Solumedrol, after which she improved clinically and then was transitioned to oral prednisone. She was then extubated and returned to floor level care. Unfortunately, she actually decompensated as a result of hemorrhage due to a peripancreatic drain placement for acute necrotizing pancreatitis, which was then followed by a multiple organ failure that continued to worsen. She was made comfort care, and then she was terminally extubated. Basically, though, for macrophage activation syndrome, you can have a genetic predisposition, and then with background inflammatory activity and then a trigger such as infection, you can set off this storm from a macrophage activation syndrome, which can cause these pancytopenias. On immunohistochemical assessment, you can see numerous CD8 T lymphocytes and maybe some rare CD4 T lymphocytes. The point of this kind of was the macrophage activation syndrome can present quickly and with multiple organ failure. In patients with other rheumatologic conditions, rapid identification is important for appropriate treatment. In severe cases, they may require cyclophosphamide and or rituximab, especially if there's a lack of initial response to treatment or worsening disease. And there is classification criteria that's been printed before that's been shown to aid in the early detection of macrophage activation syndrome as well. Thank you.
Thank you. Next is Austin Macadia, but I know someone's filling in for him. It means we're done.
Oh, sorry, I am here. I'm just trying to share my screen. No, I'm Ira.
Oh,
Meta.
no, Ira. Okay, I see you. Okay.
Okay. Good afternoon. My name is Ira Meta, and my presentation is the effectiveness of apigenin as a potential histone deacetylase inhibitor. So chemoprevention is a modality which uses naturally occurring dietary agents or chemical compounds to intervene in the early stages of cancer. Apigenin is a bioactive compound commonly found in various fruits and vegetables and exhibits anti-cancer properties. Maspin is a secreted protein encoded by a class II tumor suppressor gene, and its role is well established in cell migration. Maspin exerts endogenous inhibitory effects on class I HDACs, or histone deacetylases. Class I HDAC levels are increased in prostate cancer, and their aberrant expression correlates with decreased tumor suppressor activity, drug resistance, and poor prognosis. So this study evaluates the effect of apigenin treatment on Maspin expression affecting the migration of prostate cancer cells. The goal of this study was to test the effectiveness of apigenin on increasing Maspin expression in prostate cancer cells. Apigenin has shown to inhibit class I HDAC activity, and whether this decrease has an effect on Maspin levels has not been elucidated. This study used human prostate cancer LNCAP and DU145 cells. These cells exhibit constitutively high class I HDAC activity and low Maspin expression. The cells were then treated with 5 to 20 micromolar apigenin and 25 nanomolar trichosanin A, which is a class I HDAC inhibitor, for 24 hours. The cells were then subjected to migration assay, and in our results, we found that apigenin treatment caused the inhibition of cell migration in these cells. Next, we performed Western blotting. Exposure of these cells with 5 to 20 micromolar apigenin resulted in dose and time-dependent increase in Maspin expression, inhibition of HDAC activity, and P53 activation. There was no significant change in HDAC's protein expression after apigenin exposure in both cells. Discontinuation of treatment with apigenin resulted in the loss of Maspin, P53 acetylation, and decreased migration of these cells. Apigenin withdrawal also resulted in an increase in HDAC expression in prostate cancer cells. In conclusion, apigenin has shown to be effective in increasing Maspin levels and successful in inhibiting the migration of prostate cancer cells. Apigenin has also shown its ability to inhibit class I HDAC activity. These studies further demonstrate the potential beneficial effects of apigenin that may lead to the development of novel, safe, and effective therapeutic strategies in the management of prostate cancer. Thank you.
Thank you, everybody. This was great presentation from all of you, and we really appreciate your time and effort that you have put into this research showcase and your posters and abstracts and being on time. Do you have any questions? Anybody has any questions for any presenter, or you have questions for us?
I don't think so.
Okay. So, we will be announcing the results, and we will get back to you soon with the winners. So thank you once again, everybody. We really appreciate. Have a nice day.
Hello, everyone. Welcome to the 9th Annual Research Showcase. I will be the moderator for today. My name is Ron, and basically we will be just going down the list of presenters and looking forward to seeing all you guys present today. I am having some issues with my video right now, so I'll try to get that fixed here as soon as I can. But before we begin, there are a few things that I want to make sure you all know. So when it is your turn, please already have your poster open to present beforehand. So I would suggest you open them now in case we're missing people and we get ahead. Two, we're going to have a timer running. You will have 3 minutes to present. So please try to restrict yourself to that time. Otherwise, the other moderator will cut you off or mute you at that time. And that is all. So is Ibrahim. So if you wanna share your poster and we'll get a timer started here.
Okay. African American have higher incidence and mortality from prostate cancer when compared to Caucasian American. But till now, we don't have a clear explanation for this racial disparity. But in our recently published study, we noted that the tumor adjacent stroma was more hyperreactive with African American and showed more expression of a stromal cell-derived factor called CXCL12, which is normally physiologically expressed in lung, liver, and bone, which are the most common sites of distant metastasis for prostate cancer. And also it is expressed in musculofibrous tissue and normally react with CXCR4 in these areas. So we decided to investigate CXCR4 expression in prostate cancer areas and its relation to the more aggressiveness and the more bad prognosis with African American. Our theory depends on two items. The first thing is that these sites are the most common sites of distant metastasis, lung, liver, and bone, and these sites are rich with CXCL12, which react with CXCR4. This may induce CXCR4 positive cancer cells for recruitment of these cells to these sites and initiate metastasis. The second thing is when CXCL12 released from the stroma and combined with CXCR4 in the membrane of prostate cancer cells, this complex induce inflammatory and immune response, release of interleukin-6 lead to hypervascularity and MMP9 by macrophages, degrade the cell membrane and make cells lose easy to migrate and invade, and this complex translocate into nucleus make cells more invasive. This can get cells to get access to blood vessels, microvasculature, and lymphatics, more distant metastasis, more bad prognosis. So we did immunohistochemistry for paraffin embedded section for prostate cancer sample from both groups, African American and Caucasian American, and we tested staining for CXCR4, interleukin-6, and MMP9, which was higher with African American. We did also cell culture for prostate cancer cell from both groups and evaluate the stroma which more hyperactive with African American when compared to Caucasian American. We also proceed for testing with Western blot testing for the interleukin-6, MMP9, CXCR4, which was higher in African American when compared to Caucasian American. So our conclusion is that tumor adjacent stroma play an important role in the aggressiveness of prostate cancer in African American when compared to Caucasian American, and the higher CXCR4 expression in prostate cancer areas can be used as a prognostic marker. The more expression, more bad prognosis, lower expression indicate better prognosis, and it can be used also as a novel therapeutic target. If we can add a drug to suppress its activity, this may help to improve prognosis in prostate cancer patients in the future. Actually,
thank you, Ibrahim. Sorry, we'll have to cut you off here. That was very interesting work. And so next up, can we please have Krishna, if you're ready?
Yeah. Give me 1 second just to full screen it. Okay. Today, we're going to be talking about big data analytics and to characterize the tremor prevalence of regularity in neck dystonia. Dystonia is the third most common neurological disorder characterized by abnormal twisting and turning of the body parts. It is frequently associated with tremor. About 3 million people worldwide suffer from this devastating neurological disorder with limited treatment options. Importantly, neck dystonia is the most common form of dystonia and affects about 1 million people. Now, the presence or absence of neck dystonia and when it's regular, irregular, or jerky tremors is important in determining the care pathway for the patient. And when we have an incorrect care pathway or incorrect diagnosis, it will lead to years of poor quality of life and the waste of billions of dollars in revenue. This brings us to our aims. We analyzed the world's largest cohort of neck dystonia patients, about 3,117 individuals collected from 52 movement disorder centers worldwide. And we use the big data analytic principles are used to evaluate the historically largest data set in order to predict the features of neck dystonia that are associated with the presence of tremors. We also compute the predictive measures of regular versus irregular tremor types in neck dystonia patients. The ability of predicting co-occurrence of tremors and if it's regular regular will facilitate accurate diagnosis and initiate ideal care path. And as you can see on the map here, this is where we collected the data from. And you can see different characteristics of our data sample. And now for our methods. For the interest of time, our methods were primarily used on the big data analytic principles. And from our data, we found that about 58% of the patients had a tremor. And of these 58%, 19% of the tremors were regular, 24% were mixed, either regular or irregular, and 57% were irregular tremors. Now, the first analysis we ran was based on the tremor prevalence, whether or not the person had a tremor or no tremor at all. And we found that and we use the variables of the dystonia severity of the neck, the duration of the dystonia, the age of the patient, the severity of dystonia elsewhere in the body, the gender of the patient, the site where the dystonia was actually checked out, the race of the patient, the dystonia location, and the handedness. And we found that the more severe forms of neck dystonia, the longer disease duration and the patient's age in descending order, particularly the presence of the neck tremor. And the probability of the tremors reduced the dystonia affected other parts of the body in addition to the neck. And we also ran another analysis on the irregularity of the tremor, and they were both comparable. For the first one, we identified the irregularity predicting parameters in reference to regular tremors, and the second one was versus no tremors at all. And they both found that the GDR, that the severity of the tremor in other parts of the body, along with the age or duration of the patient and the disease, were the leading factors in determining whether or not they had a regular tremor or no tremor at all. So in conclusion, we found that using the largest patient cohort in the big data analytics, we identified the most relevant clinical traits that can predict the current co-occurrence of tremor prevalence and irregularity in neck dystonia. Thank you.
All right, thank you. So next, if we can have Alexander.
Hello, and thanks for having me. I'd like to present two cases which highlight a novel use of deep brain stimulation, or DBS, for treatment of neurologic disease. To give you a brief overview of DBS, the patient has two electrodes that are inserted into the deep nuclei of the brain, as depicted in the bottom right. And in this case, it's the globus pallidus internal segment, which are connected to a pulse generator in the chest. Its mechanism of action is thought to be a combination of direct neuromodulation, alteration of oscillatory activity, and alteration of synaptic plasticity. We perform these surgeries quite a bit at UH, and we have a lot of success in treating dystonia. We're the only center, as far as I know, that does all asleep surgeries, all in one operation, which patients tend to appreciate. So getting into the case, as an introduction, oculopalatal tremor, or OPT, is caused by lesions involving the Guillain-Barré triangle, as shown in the diagram on the left in the brain stem. And when patients have a lesion there, commonly a stroke, they get this reactive inferior olivary hypertrophy that leads to aberrant cerebellar output, and thereby causing rhythmic ocular and palatal movements. Patients with lesional OPT often develop concurrent dystonia, and that's because they have abnormal cerebellar outflow. And we actually termed this syndrome oculopalatal tremor plus dystonia, or OPTD. And DBS has been targeted at the GPI to treat dystonia, but not previously in the setting of this condition. So case one is a 61-year-old man with a history of multifocal strokes who developed oscillopsia. His exam showed oculopalatal tremor and a moderate degree of truncal, laryngeal, cervical, and limb dystonia. His MRI showed the findings of right olivary hypertrophy. Following GPI DBS, his dystonia improved significantly. His global dystonia severity scale improved from 16 preoperatively to 10 postoperatively. In case two was a 56-year-old woman who has a history of bilateral cerebellar infarcts, who later developed dystonic movements of the face, upper trunk, and left arm. She was found to have OPT. Her MRI again showed bilateral olivary hypertrophy, including a lesion involving the central tegmental tract. And following DBS, she had marked improvement in her dystonia, with her GDS improving from 25 preoperatively to 8 postoperatively. So in conclusions, dystonia is thought to be resultant from a disruption of a network including cerebellum and basal ganglia. And it's hypothesized that patients with OPT are predisposed to developing dystonia. And these two patients had success in treating it with DBI, likely because of modulation of the dentato-thalamocortical pathway.
Thank you, Alexander. If we can please have Jonathan go next.
All right, sorry about that. Can you see it now?
Yes.
Okay, great. Artificial intelligence guided customized rehab for Parkinson patients. I'll get right into it due to lack of time. My name is Jonathan Cunningham. Sorry about that. Successful rehabilitation leading to a favorable course of movement disorders and Parkinson's disease is contingent upon frequent, regular, and patient-specific exercise regimens that is customized to individual needs. So the lack of access or homebound status are significant hurdles in delivering effective rehab. We have found this in our patients. Our vision is to offer customized rehab using a remotely operated, customized, and remotely monitored technology near or at a patient's home. The proof in this concept was already established in our laboratory, a technology called dynamic cycling. The highlight of this technology is a stationary bike operating at a rapid sequence or cadence with a programmable variability in speed and power and torque, hence promoting the motor performance superior to traditional motorized bikes, i.e. static cycling. Here we present the next step towards our ultimate vision of at-home exercise therapy, a remotely operated dynamic bike. The origin came from a Parkinsonian patient that did well after tandem biking. Further study revealed that forced exercise during tandem biking might determine improvement in Parkinsonian movement symptoms. So we found the variability in the forced cycling cadence is a much stronger determinant of success after tandem biking. So applied in the lab, the patient rides a computerized smart bike. Wearable sensors measures patient's Parkinson's symptoms in real time. Wearable sensors also are located on the bike. They're both connected to a secure cloud. The cloud is connected to a laboratory computer where artificial intelligent models are generated and implemented for adaptive bike performance in the next section. Adaptive bike performance is aimed for better control of Parkinson's symptoms. So essentially a person was measured pre and post. That information was uploaded into the cloud. Artificial intelligence made improvements to the bike's variability throughout a total of 12 sessions, 3 times per week over 4 weeks. And there were some conclusions drawn from that. And as you can see from the patient 1 and patient 2, this information was extrapolated where wearable sensors data from 2 individuals with Parkinson's disease whose symptoms were assessed before, the pre is the maroon bars, and after post the gray bars during 3 sessions of dynamic cycling. Category of the motor symptoms are placed on the x-axis, y-axis depicts motor scores characterized in finite values ranging from 0 to 4. As you can see, this was an improvement.
Okay, thank you, Jonathan. Next up, can we please have Abdul?
Okay, so hello, I'm Dr. Armashi. I'm internal medicine resident at St. Vincent Charity Medical Center. First, I would like to thank AIPNO team for giving us the opportunity to present our interesting cases. Today, I have 2 interesting cases to present. The first one, my poster title is COVID-19 necrotizing pancreatitis and abdominal compartment syndrome, a perfect cytokine storm. This case report was done under supervision of Dr. Keivan Ravaka. I would start with a brief introduction. COVID-19 induced an immune response leading to an elevation of pro-inflammatory cytokines. This cytokine storm has potential to aggravate any previous ongoing inflammation. Moreover, acute pancreatitis can cause local necrosis, thereby causing extensive abdominal inflammation. This condition increases the risk of abdominal compartment syndrome and its complication. I will start with our patient, a 37-year-old male with a past medical history of chronic pancreatitis, alcohol use disorder, who presented to the emergency department complaining of abdominal pain. Physical examination revealed a tender abdomen. Initial workup showed elevated amylase and lipase, positive COVID-19 PCR test, and elevated inflammatory markers. The patient denied any respiratory symptoms. Initial abdominal CT scan revealed mild pancreatic inflammation, so the patient was admitted to the respiratory care unit and was managed with fluid restriction and pain control. However, the patient has increased oxygen requirement leukocytosis, and worsening kidney function. Transbladder measurement of intra-abdominal pressure revealed severe abdominal compartment syndrome. So broad-spectrum antibiotics were started with, okay. However, after 72 hours of treatment, the patient had a cardiopulmonary arrest. He returned to spontaneous circulation after advanced cardiovascular life support protocol. A repeat CT scan of the abdomen showed necrotizing pancreatitis and large volume hemoperitoneum, as seen in figure 1 here. Urgent pancreatic necrostomy was performed with drainage of the hemiperitoneum. The patient after that was transferred to an LTAC facility for extended antibiotic therapy, where he eventually recovered. So our case illustrates the catastrophic consequences of necrotizing pancreatitis complicated by sepsis, acute abdominal compartment syndrome in a COVID-19 positive patient.
Okay, thank you for that presentation. If you would like, we can get started with your second case presentation as well.
Okay. So my second poster, the title is zonisamide-induced hallucinations. So a brief introduction, zonisamide is a new generation anticonvulsant that works by altering the sodium and calcium channels in the brain. It's currently approved for partial seizures, and trials are ongoing to evaluate the effectiveness against mania and chronic pain in adults. Psychosis.
Abdul, I'm sorry to interrupt you. Can you please share your poster as well?
Sure. So psychosis is a rare side effect of zonisamide with an incidence of only 2%. So our patient is a 52-year-old female with a past medical history of osteoarthritis and chronic pain, only relieved by zonisamide. She came to the emergency department after 2 days history of altered mental status, agitation, and visual hallucinations. 1 month prior, she had undergone total knee arthroplasty complicated with right knee cellulitis, managed by IV long-term antibiotics of vancomycin. Physical examination was positive for disorientation to person, place, and time, with intact reminder of neurological exam. Lab work was unremarkable, and CT brain also showed no acute abnormalities. The patient initially was treated as ertapenem-induced altered mental status, and the antibiotics was switched to meropenem on discharge. 2 weeks later, the patient presented to the ED with similar non-resolving complaint. As the patient's symptom did not improve after ertapenem discontinuation, the decision was made to stop zonisamide and carefully monitor for possible withdrawal symptoms. Fortunately, our patient had timely resolution of her symptoms with a full return to baseline within a week. So this case demonstrates the potential severity of zonisamide-induced psychosis. And also here we highlight that additional studies are warranted to analyze the mechanism explaining its neurological side effect profile. Those are my 2 posters, and thank you so much.
Thank you. And then next, if we could please have Pata.
Okay, hi everyone. Thank you for having us at AIPNO. I am a St. Vincent resident and would like to present a very interesting case under the supervision of our program director, Dr. Keyvan Ravaka. So as an introduction, HIV-positive individuals are at an increased risk for kidney diseases, including HIV-associated nephropathy, focal segmental glomerulosclerosis, HIV immune complex kidney disease, HIVIC, and acute tubular necrosis. Non-modifiable factors such as age and genetics, as well as modifiable factors such as illicit drug use and compliance, define the progression to renal failure. And here's my interesting case. So the patient is a 64-year-old African-American gentleman with HIV, treated latent syphilis, chronic kidney disease stage 3A, and cocaine use disorder, who presented initially with shortness of breath, bilateral lower extremity swelling, and fatigue, with normal vitals and a physical exam otherwise. Remarkable for bibasilar inspiratory crackles and peripheral edema. Laboratory tests showed creatinine of 2.23 with a baseline of 1.5, albumin of 1.8, BNP of 667.88, and lipidemia. His urine was remarkable for proteinuria and macroalbuminuria in the presence of cocaine. Immunofixation electrophoresis showed a marked increase in IgG and IgM, free lambda, and free kappa over lambda ratio, with HIV viral load of 39,400, with an absolute CD4 count of 56 and acute hepatitis B panel being positive. Renal biopsy confirmed HIVAN, which is HIV-associated nephropathy, and FSGS accompanied with collapsing features, HIVIC, which is the HIV associated with the immune complex disease, and acute tubular necrosis. The patient was subsequently started on highly active antiretroviral therapy, as well as prophylactic antibiotics with close monitoring. As our conclusion, this case highlights that HIV-positive patients are at an increased risk of developing complex focal, glomerular, immune, and tubular kidney pathologies, especially in the setting of acute infections, such as hepatitis B in our case, drugs, such as cocaine in our case, and non-compliance. HIVAN and HIVIC can coexist in some cases, mostly in the context of patients being off their antiretroviral treatments, of course in the setting of low CD4 counts and high viral loads. Thank you very much for listening. You can see here the findings of FSGS, the sclerotic areas, the crescent-like appearance, and if you have any questions, if I have remaining time.
Thank you for that presentation. And is Mohammed here?
Let me know if you can see my poster.
Yes, there we go.
Perfect. Thank you. So good evening. My name is Celine Puzio, and I'm one of the internal medicine residents at the Cleveland Clinic. This is my case presentation called Hold Still, a large neck paraganglioma limiting head movement. So this is a 79-year-old man who presented with an unusual case of a functioning cervical ganglioma, as 95% of parasympathetic tumors are normally non-functioning. He was originally diagnosed 10 years before presentation, and surgery was recommended at that time. He, however, was lost to follow-up and represented to the ED 10 years later, following several syncopal episodes, leading to falls and injuries at home. He also complained of severely limited neck movement to the left side or the side of the mass. Measurement on imaging performed in the ED showed the mass had increased to approximately 7.7 centimeters in its largest diameter, as you can see in image 1. Symptoms were worsened by neck movement and sometimes resulted in sweating, elevated blood pressure, and headaches. Due to his elevated blood pressure, he had required ICU admission for closer monitoring. During admission, his blood pressures would range from low readings, approximately 7/40 millimeters of mercury, to a maximum of 340/115 millimeters of mercury, which changed in only a few minutes. We were able to start him on alpha blockade with low-dose doxazosin, as his lower blood pressure could not tolerate a larger dose. Workup for plasma catecholamine shows significant elevation in metanephrines, norepinephrine, normetanephrines, and dopamine, indicating that the paraganglioma was productive. MIBG scan showed impressive uptake in the mass, as you can see here in image 2. He was evaluated during admission for possible surgery, but was a poor candidate due to the invasion of the mass into the internal and external carotid arteries. He was able to undergo 5 treatments and radiation to help with signs and symptoms of the mass and was ultimately discharged from the hospital. What we learned from this case is that we should always be aware of presenting symptoms of a functioning paraganglioma, though rare. They can have profound side effects on blood pressure, in this case causing both high and low blood pressure. We should be vigilant for complications of these pressures, including stroke and end organ damage. And most importantly, these patients may require ICU level of care for management of their extremely labile blood pressure. Thank you for your time.
Thank you. Next, do we have Avisha here? Okay. And then after that is Isaac.
Hello. Hi, guys. Yes, I have a case, and just a second, let me share that with you guys. So our case is, he's a man, a 62-year-old male with a history of multiple surgeries at the lumbosacral region due to herniated disc. So he was admitted for redo because of the chronic back pain. And on the next day after the surgery, he started to have this kind of severe headache, 8/10 with photophobia. He was on some anti-analgesics and some narcotics for the back pain after surgery. So he said to me, I may use them, I'll be okay. But the headache continued and he started to have a back pain also. So he came back to the hospital. They thought that's maybe meningitis, maybe there's a complication from the surgery. They did the lumbar spine CT scan. There was a fluid. They took him to the operating room. They drained that fluid. The fluid was clear, was not infected. The cultures were negative. Due to continued headache, they did the CAT scan of the head, and that's shown here in the CT scan. And that's where is the interesting part. If you look to the CT scan, you will see an air inside the brain parenchyma, which called the pneumocephaly. You can see it also on the sagittal screen here. But there is no sign of infection and was not suspicious for infection. More detailed and more imaging were required. Also, reviewing his anesthesia and operative period, there was no penetration to the epidural. So it was the epidural leak and CSF leak was not in the picture. So an MRI was done, and when they did the MRI, they found this changes in T2, which is, as you see, hyper intensity, just like the CSF color. And with subtraction of the CSF with a flare image, you still see here the apex of the horns of the ventricle. There is some hyper intensity. In T1, you will see like this small kind of foci and drops hyper intensity in the subarachnoidal space. And that was suggestive for fat drops. And if you're reviewing this case and looking back, this is suggested by a ruptured dermoid cyst. We don't have an imaging to compare previously to see that dermoid cyst, but it's been said that it's around 0.04 up to 6% of the intracranial tumors are due to dermoid cyst. And rupture of this cyst actually is very, very, very rare and unlikely. You have to watch that for complication, and MRI is the best option for early diagnosis and avoid complication. Thank you very much. And that's Isaac, St. Vincent Hospital.
Thank you. Moving on. Do we have Amid here? I do not see him. What about Ferris? Also not here. Hadil? Okay, and then
Hadil is not here. I was on the same case. Do you want me to present her case?
Sure, if you would like to.
Okay, no problem. Let me share my screen with that case for Hadil. So Hadil, she has a case of, so Hadil Abutir, also from St. Vincent Hospital, and she has a case of unusual presentation of acute immunoencephalitis, which is called Adam disease. This young man, he is 17 years old, came to the hospital with severe right side lower limb or right leg weakness. Then the symptoms start to progressively increase and worsening over a couple of hours. He starts to have whole right side body weakness, then seizure attacks. Then he wants to status epilepticus that required intubation and put in a mechanical ventilator. But the interesting part, when they did the CAT scan first time, they thought there is a hypodense lesion. If you see here on this right, this is a hypodense lesion that compression the ventricles, and with a midline shift, also it's here more clear. So it was unusual for a mass to do that. So they did an MRI. And if you look to the MRI here, the MRI showed that lesion is more of mass-like, which is also here in the MRI. You can see it. Let me scroll down. So again, this is the CAT scan with the hypodense lesion. That is as X-ray. Yes, here is the mass with hyperintensity, and this is the T2. If you go down, there is another T2s with hyperintensity. This mass and compression in the midline, again in the sagittal area. But the symptoms rapid progressive. It was unlikely to be an astrocytoma or lymphoma in the differential diagnosis. It was more likely of a demyelinating disease. And if you're reviewing the demyelinating disease for young kids, you will find this Adam disease is very more common and even from 4 to 10, 12 years old. And they have a very symptoms of presentation, just almost like an MS for an adult. The interesting part is looking like a mass occupying lesion. So they commit treatment for him with plasmapheresis. We started him on IVIG, pulse steroid, and he got recovered with total full recovery within 6 months. And the discussion part is to recognize this disease early. The age was not as common as for young kids. It's more in young kids. And even if it's a mass-like, there is a very rare and very low possibility to be also an Adam disease that required immunosuppressant treatment instead of the mass that required surgical intervention and the malignancy possibility. So that was the case, and thank you very much.
Okay, thank you. Next, we have Alimitha, and let's see, I can try to share your poster.
Thank you so much.
Yes, just one moment.
All right, thank you. I don't know if my video is showing. Hi, good afternoon, everyone. My name is Alimitha. I'm one of the, and today I'm going to be presenting a case that we saw beginning of the year. It was a patient, it's a rare case of hypophosphatasia, familial hypophosphatasia. So before I go on to the case, a little bit of introduction. This is a condition that is an inborn error of metabolism where we see low serum alkaline phosphatase activity that causes loss of function mutation. That's caused by a loss of function mutation in a gene that produces alkaline phosphatase. And just a little bit information, this is an important enzyme that is actually necessary for presentation or for development of bones in the fetal age and as we grow older. So we have a case here of a 55-year-old female with a past medical history of seizure disorder, hearing loss, and osteoporosis. And she initially presented to our clinic with for evaluation of multiple stress fractures. She also had some gum disease with gradual hearing loss at the age of, gradual loss of teeth at the age of 16. And she's also had multiple pain in bilateral thighs by the time she was 47. And she had multiple fractures as well, for which she needed rods placed in both femurs. So the reason this case was unusual is that she was initially diagnosed as osteoporosis and treated with multiple anti-resorptive medications in the beginning at the time of diagnosis until much later, probably 5-7 years into her diagnosis. It was later recognized that she was a patient with familial hypophosphatasia that was unrecognized as a child, that she went through all of these consequences and finally finally reached to a stage where she became debilitated. She was finally treated with aspartase alpha, which is actually a medication that it's an enzyme therapy that was recently started. It was recently approved in 2015 for the treatment of hypophosphatasia. And it's only approved in adults. It's only approved in infants and childhood hypophosphatasia. But this patient was able to get it back in 2015. And since then, I think, as I showed here, after she received this medication, she did develop significant improvement in her quality of life.
Well, thank you, Alimitha. I'm going to end the screen share here. And then if we can have Cody.
Yes, is my screen presenting currently to you all?
Excuse me, can you hear me? Hello?
Yes.
Okay, sorry about that. And then is my screen presenting?
Yes.
Perfect. All right. So my study is labeled Binocular Visual Function Deficits in Amblyopic Patients with and without nystagmus. So amblyopia is the leading cause of blindness in children, affecting about 1 in every 20 children, and has a prevalence estimated worldwide at 99.2 million. And this can result from congenital cataract, difference between eye refractive errors, or eye misalignment, i.e. strabismus. So amblyopia includes compromising deficits, which these impair sensitivities to contrast or contrast sensitivity. They affect depth perception, and they also cause, or amblyopia also causes overriding of the amblyopic eye input, which is the suppression of that amblyopic eye, along with poor fixation. And amblyopia can affect daily tasks such as reading and environment navigation, which therefore potentially affects academics and physical and social abilities. So long-term concerns with vision loss of the fellow eye. Critical periods are from birth to 7 years, and therefore the purpose of this investigation was to examine binocular spatial contrast sensitivity in envelopes and the effect of nystagmus as determined by fixation eye movements. So patients either in figure 1A sat 1.5 meters away from a screen in a quiet setting, and they were assessed with Gabor patches on spatial frequencies of 1, 2, 4, 8, and 12. And this was in a one up, one down manner. And then patients also stared in a screen for 80 centimeters. And this was with using high resolution cameras to determine eye patterns in a horizontal and vertical plane for classification of nystagmus or those without nystagmus. So on figure 2A on the left here, it notes that the data points on top are controls and on the bottom are amblyopes. And at spatial frequencies 8, 12, and 16, controls have a higher log of contrast sensitivity. On the right there for figure 2B, controls have a higher area under the curve of the contrast sensitivity at spatial frequencies 8 through 12 and 12 through 16. Now breaking these groups into either controls, those having nystagmus, or none not having nystagmus, it was actually the none group that had less than the control for spatial frequencies 1, 8, and 12. And then additionally, none had a lower area under the curve for spatial frequency 8 through 12 and 12 through 16. So conclusion, amblyopia is not only a monocular problem, it's also an important implication for binocular viewing. Those with nystagmus actually had better contrast sensitivity, and we think that's because they had more mixed strabismic in the group, and they're traditionally better at contrast sensitivity per given visual acuity deficit.
Thank you, Cody. Next, could we please have Krithika?
Can you see my screen?
Yes.
Okay. So today I'm going to talk about, hi, I'm Krithika, and today I'm going to talk about CFTR modulator therapy on lipid levels. So basically, cystic fibrosis is a common genetic disorder that occurs due to mutation in the cystic fibrosis transmembrane regulator. CF classically affects the lungs, causing progressive pulmonary disease, but it can also manifest in disease of the pancreas, liver, intestine, and reproductive organs. So CFTR modulators are a novel class of medications that help restore CFTR function. Symdeko and Orkambi are older medications that provide modest improvement in CFTR function, while Trikafta is a newer medication that is highly effective at restoring CFTR function. In the past, CF has been associated with malnourishment, but now there are an increased number of CF patients who are actually obese and overweight. Research states that this could be due to the high-fat diet introduced in the early years of CS that leads to the formation of unhealthy eating habits later in life. And if modulator therapy restores the function of the channel, the combination of both of these could lead to increased weight gain, heart disease, and other conditions. There is limited research that assessed the effect of modulator therapy on lipid levels, which is what the aim of this study was. So basically, 30 adults with cystic fibrosis underwent abdominal MRI to assess the protein density fat fraction while treated with Symdeko or Orkambi, no modulator, or Trikafta. Retrospective chart review was used to evaluate BMI and ppFEV1 within 3 months of MRI, and serum lipids were recorded if it was taken within a 1-year time period from MRI with same modulator status. Of the 30, only 8 patients had data available before and after Trikafta, and 8 patients had data available before and after a modulator was added. And then a paired Wilcoxon's test was used for analysis. For the results, basically before and after Trikafta, there were significant increases in the ppFEV1, BMI, median LDL-C, and median HDL before and after Trikafta. For no modulator versus any modulator, there was significant increases in median BMI and median HDL, with median HDL approaching statistical significance, and both groups showed no changes in the PDFF. So basically, in conclusion, treatment with the highly effective CFTR modulator Trikafta is associated with elevated levels of HDL, LDL, and BMI. Hepatic steatosis, which was measured by PDFF, did not change as patients transitioned between modulators. The study was limited by sample size and the number of patients that got pre and post scans with lipid levels performed within 1 year. And especially in the no modulator to any modulator group, we included Symdecto, which could have confounded some of the elevated lipid levels from the Trikafta group. So further research is definitely needed to investigate the mechanisms of the higher lipid levels in cystic fibrosis after modulator treatment and see if it does actually cause an increased risk of cardiovascular disease.
Well, thank you very much. I would like to thank you all for being here and presenting. Those were very interesting posters. We will be collecting all the judges' scores. We're collecting them as we speak right now, and they should be all calculated by the time when they're supposed to be announced during the gala. I do not believe it's the first thing that'll be announced, but it'll be during that time. So good luck to all of you, and thank you for presenting, and they were all great. If you guys have any questions, feel free to send them my way. Okay, so with that, thank you for being here. Good luck to you all, and I hope to see you guys at the gala.